But now we've got practitioners, people like me that are going into perimenopause and thinking, wait a minute, I have a brain. I can look at data. I can figure this out for myself. And that sort of has, resulted in this kind of avalanche of information being made public. It was all there. Just people didn't know about it. And getting out there and telling people, I know we're the generation that saw our mothers not be offered hormones, and we've seen the outcome of that. And we're not prepared to allow that to happen to ourselves without a fight.
Yes.
And I think that's the biggest difference. Menopause isn't having a moment. HRT isn't having a moment. It's just a matter of trying to bring it back as a tool and an option when we talk about treatment of symptoms, but also prevention.
I'm Jessica Vallant. I'm a physical therapist, women's health expert, and Pilates teacher, and my goal is to help all women feel strong, safe, and secure in their bodies. In this podcast, I'll share expert advice, facts, amazing guests, stories, compassion, and hope to help you meet your body in all seasons of life. Hi, everybody. Thanks again so much for being here for this episode of Meet Your Body. I am so excited to introduce you. You heard the introductions, but we have our special guest here who I know you go by Noor. Is that correct? Okay.
Yeah.
Awesome. Tell us your story, like whatever part of your story you want us to know, how you got to where you are now, why you are so passionate about women's health, a little bit of all of it.
Yeah. So my name is Dr. Noor Al-Humaidhi. I'm a board certified family physician. I had a very winding road to where I've got to today. I actually went to medical school in Dublin, Ireland. And then I did my training in the UK, actually just outside of London. So I was trained as a GP in the UK, which is very different, I think, than how the training is here.
Yeah.
And I lived there. We lived there for 10 years. I had my children there, and we moved here 8 years ago now. It was many things kind of came together that resulted in my husband was offered a job, and my mother was retiring, and she's from here. So that we moved. It was kind of on a women of prayer. So we moved 8 years ago. And at the time, because I didn't do my residency here, I didn't think that I could get boarded. So there was a bit of a roundabout way. Eventually I was able to get my medical license and get boarded. And I started my, back in a career in primary care, the same as I had done previously in the UK. I had always had an entrepreneurial spirit and felt like I was needed to be doing something. And I couldn't quite put my finger on what it was that I needed to be doing. And that all happened around sort of when I was 38, and I started to have these symptoms, which now I know were perimenopause symptoms. It was COVID. They closed my office. We opened a respiratory clinic and a COVID clinic, and it was really, really stressful. And I thought, I'm just really stressed. And obviously my kids were in school, not in school, being homeschooled. I was seeing COVID patients, and I thought, this is just, I'm just so stressed, and I just need to kind of suck it up. Anyways, my symptoms sort of persisted, and I eventually saw some specialists. I was diagnosed with, psychiatric conditions and treated, and I didn't improve. And I just did not, and I just kept getting worse from a psychiatric perspective. And I ended up scrolling Instagram one day, and it was sort of a aha moment that I hadn't even thought of it, that this was menopause, was perimenopause. And that sort of sent me on a huge deep dive. And I learned everything I could. I went to all the conferences, I took all the tests, read all the books, got into all the, group chats that I could, the WhatsApp messaging chats, anybody, please give me information. And, was able to find the treatment that I needed. Right. And once I felt immediately better, and I often tell people, it was just overnight for me, the difference to my mental health of going on HRT. And I thought, I can't let this happen to other women. I need to bring this care to other women because they're being neglected and nobody is fighting for their corner, especially from the mental health perspective. I know I talk about bone loss. I talk a lot about, cardiovascular risk, but really for me, it was the mental health. Women go through a mental health crisis in perimenopause, and we're not recognizing it. And that's just not good enough. So I founded this Lifestyles by Noor about, I keep saying 18 months, but it's actually a little bit longer than that. And it's just been a whirlwind.
Yeah. Yep. And I would love to know, because I know physicians here in the States, obviously the menopause training is little to nothing. Did you have anything different in the UK? Or is it the same? Is it really worldwide that we are not training our physicians on perimenopause, menopausal transition care?
So, I was in medical school in 2002 when the WHI was published. And I remember it was like, we don't put people on hormones. That was the message, basically. So I got little to no training, both, in medical school and in Dublin, and then during my GP practice training. But I do remember, it's so interesting. I do remember during the full year that I spent in a general practice as a trainee. Mm-hmm. And there were some of the older doctors were doing HRT. And it was kind of like, oh, they do HRT, we don't do, they were kind of like off on a tangent doing it. And they were doing HRT for women that, and kind of the rest of us sort of just didn't go there and didn't even kind of scratch the surface. But I even remember, being all weird about prescribing vaginal estradiol and cycling it because you don't want to give too much estrogen. And what about the uterine lining? I mean, vaginal estradiol, we were worried about. So, I mean, it just shows you the depth of the misconception there was at that time around the use of HRT.
Yes. And why don't we use this as, and I know we could do hours upon hours about talking about the Women's Health Initiative study and the problems with that. Give us a really high level of, I think so many women are thinking, oh my gosh, it's just HRT is having a moment right now and it's a trend and it'll go away. And I want women to understand why we are suddenly talking about it, because we really should have been talking about it for the last 20 years. But the problem is this study came and we were all told, yeah, no one can have it at all. And now we're finally understanding we've done women a disservice by at least not having the conversation. So can you explain to everyone, again, high level, what the Women's Health Initiative study was, what we thought then, and what we actually know now to be true?
Yeah. So prior to really the WHI, so really right up until the 1990s, it was pretty well established in the medical literature that hormone therapy was beneficial. It decreased your risk of osteoporotic fracture, decreased your risk of type 2 diabetes, decreased your risk of cardiovascular disease. It was pretty well established in the medical literature. And you could kind of go back and read, it's all there, right? You can find it on PubMed. So the NIH got involved and decided they would do a study, which they called the Women's Health Initiative. And they recruited 16,000 women into groups, and they gave them, depending on kind of whether they had a uterus or not, but they gave them Premarin orally, which is a conjugated equine estrogen, orally, which comes from the urine of pregnant mares and as an estrogen. And then they gave them progesterone in the form of medroxyprogesterone acetate. And off they went on the study. And then they kind of called this huge giant press conference in 2002. And with what can only be described as a megaphone, said that hormone therapy causes breast cancer. And it's, it was sort of in the media. It was on Good Morning America. It was on the Today Show, it was on Newsweek and Time and the New York Times. It was just everywhere. And it just like percolated into, the people's blood nearly, that hormone therapy, that hormones were bad for you. And that resulted at the time in 2002 with millions of women's hormones being stopped, number one. And then the conversation, wasn't being had. And now over the years, they have walked back the data. After even 9 days after when they published the data in JAMA, it was clear that did not show what they said it showed, but it was nearly too late. They'd let this kind of cat out of the bag and they couldn't get it back in. But they have never come out with that level of megaphone and told people that we were wrong. Yeah, they've said it here and they've said it there and they've made little things here and there, but they've never said it with that same conviction that they made that statement in 2002. But now we've got practitioners, people like me that are going into perimenopause and thinking, wait a minute, I have a brain. I can look at data. I can figure this out for myself. And that sort of has, resulted in this kind of avalanche of information being made public. It was all there. Just people didn't know about it. Yeah. And getting out there and telling people. And also we're of the generation that saw our mothers suffer.
Yes.
And I'm not going to let that happen.
Yep.
So we're the generation that saw our mothers not be offered hormones, and we've seen the outcome of that, and we're not prepared to allow that to happen to ourselves without a fight.
Yes.
And I think that's the biggest difference. Menopause isn't having a moment. HRT isn't having a moment. HRT had its moment in the 60s, 70s, 80s, and 90s, and then we lost it briefly. And it's just a matter of trying to bring it back as a tool and an option when we talk about treatment of symptoms, but also prevention.
Yeah, no, that's amazing. And I had a hysterectomy in 2019. I was 40, in my early 40s. I was still cycling, and I remember the doctor wanted to take both ovaries. I'm like, no, I don't think so, because I have endometriosis. That was his answer. Just take it all.
Take it all.
I think right. I think I want to keep one, but I'm like, I will do my own research. Like you said, I can do that. I can get into the data. I know how to do this. I know how to find it. I was even shocked looking at the data telling me if I had both ovaries taken and went into early menopause, the likelihood of me having dementia, cardiovascular disease skyrocketed. And I'm like, you know what? Even if my endo stays, okay, I keep my symptoms, I am not willing to jump into that group. I am going to keep this as long as I can. And knowing that, and then just starting to hear the arguments of, okay, well, aging is natural, losing your estrogen is natural, but then saying, okay, but if I go into menopause early, I actually have these higher likelihoods of disease. So what do you say to people who do, because I know that is a big argument right now. What do you say to people who just say, you know what, it's just part of the natural aging process. I don't need to do anything about it, or women don't need to do anything about it because it's what our bodies do. Yes, it's what we do, but also what is that answer to, yeah, but I deserve to feel better also?
So here's the thing. I've cut my teeth in primary care, right? And palliative care and hospice medicine. And I can tell you that the natural way is not very pleasant. Yeah. It is deeply unpleasant. It is misery and agony, actually, for a lot of women. It is not good enough to say, well, the natural way is better. The natural way isn't actually treating us that well. Women at the end of their life are in nursing homes. A lot of times they're fractured. They have cardiovascular disease. They have dementia. They have chronic UTIs. And it's misery for years. So that if you want to call that natural and you want that for yourself, that's perfectly fine. Everybody has a choice in this, right? And I'm not telling everybody you all need to take hormones. Absolutely not. But everybody needs to have the option and know the data so that they can make the decision for themselves. But to say the natural way is better, let me tell you something. I've watched the natural way for 20 years, and the natural way is horrible for a lot of women.
Yes. And I love, and that is one reason, and I've told you when we kind of started, one of the reasons I love to follow you is you really do always push on that point of there's nuance. Mm-hmm. There is not a recipe for everyone. HRT needs to be available in the conversation, but also it is your choice ultimately, and maybe it isn't right for everyone. Can you tell us, you had a post recently where you talked about the one reason that you don't recommend HRT? I think you said there's only one reason, and it had to do with, did it have to do with the lining of the uterus, or if somebody had had a hysterectomy or didn't?
So it was about combining hormones. So people get so, I could show you my DMs and my comment. I mean, it's just like full of people with, do we take progesterone? If I'm on estrogen, do I take progesterone? Do I not? Do I take testosterone? If I take progesterone, do I have to take estrogen? If I, do I cycle it? Do I not cycle it? They just like, and is this, and my doctor says to do this. Is this right? What I said was the only rule is that if you have a uterus and you take estrogen, you must either take progesterone in some form, or there's Duavie, which is another conversation. But you need to take something that's going to limit the effect of that estrogen on the lining of the uterus. That is the only rule when it comes to HRT. Everything else is about symptom management. It's up for the debate, whether it's doses, whether it's cycling, whether it's we add testosterone, whether it's we add progesterone. That's all up for debate as long as we follow that one rule.
And I love that too. I want you all to hear, and just being a breast cancer survivor, I know there are groups specifically, but there are many groups out there who sometimes feel very left out of the conversation because, again, what happened in the early 2000s, we feel like we are just not a candidate whatsoever. So we do have to suffer through. And I want you all to hear that wasn't one of the rules she just mentioned. There are options. Maybe the options are different, but I know my oncologist, one of the first things she said to me, and I hadn't even asked, but knowing my age and knowing my history, when I walked out, she said, oh, and let me tell you, when you're ready for the HRT conversation, I am here to have that with you. Like, you are not a candidate. Like, we might have to have nuance to it. We might have to look at different options, but I will have that conversation with you. And just knowing that door was open for me was so empowering. I don't know if I'll get there, but I will say I've been using vaginal estradiol for 6 months, and it has changed my life in a lot of ways. And knowing I'm safe doing it is so valuable.
Absolutely. Go
Do
ahead.
you, how do you recommend when someone wants to have this conversation? Who do they go to? Like which one of their doctors, how do they start this conversation with someone on their healthcare team?
So I would say initially get educated,
Okay.
and there's lots of good data out there, and read Estrogen Matters. For anybody with a history of breast cancer, and really all of us should read Estrogen Matters, but especially for women with a history of breast cancer that are considering hormone therapy or in the form of estrogen or whatever, they should read this book
Okay.
and really bring this book with them.
Okay.
I would say starting the conversation with the primary care physician. People think I'm a little bit of an outlier because I'm not a gynecologist, and I'm doing this work. I think number one, we're doing gynecologists a disservice in laying this at their door, because hormones affect every part of your body. So somehow pigeonholing this into a uterine problem or an ovary problem is not fair. And hormones affect our cardiovascular risk, our bones, our risk of type 2 diabetes. They're talking about sleep apnea. They're talking about, so it actually, I think, lives in the home of a generalist that can concurrently treat all your other problems and bring it all together. So it's tied together in a nice little bow, and we can co-manage all of those things together. I think what's happened in medicine is that everybody is this silos. If we're going to do this over here, and we're going to do this over here, and we're going to do this over there. You cannot deliver good medicine or really good prevention and longevity care but with silos, because you have to understand that everything is connected. So I would start with the primary care physician, even if it's as just an ear. And I would go in there and make an appointment specifically to discuss this problem. Do not ever tack this on to a physical, or I'm in for my whatever, and I'm going to have do not do that. Have that, whatever that slot is, 10, 20 minutes, 30 minutes that you're allowed. I want you to make sure that all that time is dedicated to this conversation. I think that's something that people kind of do wrong, and then everybody gets overwhelmed. Yeah. And so making sure that you've earmarked this specific time with your primary care provider to discuss your thoughts and your concerns, maybe share your book, and start to have a dialogue about where we go from here. I think that would be the most appropriate person to talk to first.
I love that so much. And that really is the first time I've heard someone address it in that way. And it makes so much sense because, yeah, even from physical therapy, I mean, frozen shoulder, we've known for 20 years that women of a certain age, they're the ones that get frozen shoulder. And now we know why, because of decreased estrogen. So if someone goes to their doctor and the doctor absolutely is not willing to have this conversation, do you recommend continuing to try to educate, finding another doctor? Do you have thoughts around that?
So I always think if your doctor says no, you should give them something to educate themselves with and then move on. I don't think you should bang your head against a door, but I think, it's always an opportunity for learning and to spreading education. So drop the book. I'd love if you'd look at this and read this, and then, move on to somebody else, and somebody like you that has a bit of a complicated history. I would say it's unlikely that somebody that with a history of breast cancer is going to get this from their primary care provider. They're going to get it for somebody that's more doing a lot more menopause care, but also that's very much only doing menopause care. They know the data, they're in it all the time, and they are prepared to bear the risk, whatever the risk might be. Right. Even though we know that the risk is very low, but still in a lot of other doctors' minds, the risk is huge,
Yes. And what are your feelings right now? Because this is a good thing, right? That it's everywhere. The messaging is everywhere. We can now go to places like alloy.com and find prescriptions and find treatment. What are your opinions about that, knowing that it is an individualized and nuanced kind of situation?
I mean, let's not forget that half the population is going to go through menopause, right? That is a lot of people. We need to think outside the box and be prepared to offer various forms of care. And I think my alloy and MIDI, and they offer an awesome, approach to care, and it works great for some women, right? It's like, for some women, it's one and done. I'm on my, my whatever patch, and I'm great, and I love it, and I'm sailing, and that's fine. And then for others, it's a little bit more complicated. I can see maybe at a push have a panel of maybe 600 patients. What about all the other millions? Even in my area, there's no way I could see all of those people. So I think we need to make sure that everybody needs to be involved in the conversation. So people like me that do menopause care privately, primary care physicians, gynecologists, online providers, everybody really has a part to play in getting the message out and getting the treatment out to where it needs to be.
Yep. That's amazing. And tell us, again, high level, but what are we looking at, or what are the most common forms of HRT? Again, hormones, delivery systems. If women are really just starting to learn, what should they know in that aspect?
Okay, so there are many forms of HRT. It actually comes down to what we call HRT, right? Yeah. So is birth control HRT? Well, you might, maybe it is a form of HRT, right? But from my perspective, if we're talking about estradiol, so 17-beta estradiol, and we're talking about a progesterone or progestin, so 17-beta estradiol, forms that are FDA approved come in patches, they come in gels, they come in sprays, they come in vaginal rings, they come in tablets, and then they come in vaginal creams. That's kind of your options in terms of a 17-beta estradiol alone. Then you have compounding options, and people do compound things like pellets and various creams and estradiol creams. I don't generally do that here, but those are options, and people are offered them other places. Then you have progesterone. So micronized progesterone, which is prometrium, which is what we generally use most of the time, comes in a capsule that you take at bedtime. Some people do talk about progesterone creams, and that helps them with their symptoms, which is fine, but the amount you're going to absorb through your skin is limited. And if we're looking to that for uterine protection, we probably aren't going to get enough progesterone in our bloodstream to get uterine protection. So if we're looking for the uterine protection aspect of the progesterone or prometrium, it really needs to be a capsule. Now, that's orally. Some people will introduce it vaginally if people are having, trouble with symptoms of progesterone intolerance or tolerance. So that's a conversation to have. And then you've got progestins. So progestins are forms of progesterone that have the effect on the uterine lining that we are looking for, but they are not the progesterone like we make in our body. Now, some people don't tolerate progesterone, or some people they spot despite going up on the dose in progesterone. And so we need to take another avenue really to limit that effect on the uterine lining. So then we're talking about progestins, and that's going to be things, there are tablets, so things like Slin, things like Micronor, and then an IUD like a Mirena or a Skyla or a Kylena, great option. It's going to deliver that levonorgestrel right into the uterine cavity where you need it. There are some patch forms of progestin. So things like Climapro is a combination of estradiol and a progestin through the skin. So there are those sorts of options. I don't generally use those in the office. I generally find people tend to spot on those, but those are options. So there are many different options and ways that you can combine and move things around. And I always tell people, I had a client recently, I've been seeing her for a year, and it's taken us a year. She came in and she was like, I'm better. I was like, well, it took us a year. We gave her progesterone. She didn't tolerate it. We pulled back. We reintroduced it. We played with the doses. We started testosterone. We took it away. We started it again. We moved it around. It takes a while to find, it's not perfect right from the outset for everybody. And it takes a while to find the perfect combination of what's going to work for each and every person. So there are probably hundreds of maybe thousands, if you think about all the options, different combinations that we can offer in terms of HRT. And then in terms of the testosterone, I generally for women dose testosterone transdermally, but there are other options. There are, so in a form of a gel, there are injections, there are pellets, there are other options out there. I generally use a gel.
Yeah. And I think it's so important for women to know that it really isn't just one size fits all, because it's so easy, especially online right now. Everyone says, oh, just balance your hormones, take more estrogen, or take testosterone again is having a moment. Like everyone just needs more testosterone. Well, not necessarily. Mm-hmm. Yeah, right? Like what is your progesterone with your estrogen? What is your history? Yes, what method are you going to be most consistent with or that works for you? I found, the craziest thing when I started the vaginal estrogen, I couldn't figure out why my endometriosis was suddenly flaring up. I had been pretty good for a while. And I did, again, dug into the data, did my own research, and I realized, oh, it's getting up into my issue with, and so I stopped actually injecting it or having it in my vagina, and I just used the cream on the outside. Perfect. Like that was my solution. And it seems so silly, but you can't read about that anywhere. You have to be willing to understand there's so much nuance to it. And it isn't just, yeah, take this one vitamin to help your estrogen, take this one thing. I mean, you want to talk to a healthcare professional. And again, if you find someone who's not willing to talk to you, find someone else.
I think this term, like balancing your hormones, I really have a problem with that term. It like, I file it with estrogen dominance, which I also have a problem with. This idea that balancing your hormones, I feel it kind of is trying to sell a lab test, that your hormones are balanced. And I, we do use lab tests here. We do, do lab work, blood work for patients. I do track their levels, but what I'm not putting all my eggs in that basket. The only basket is the basket of symptoms and how a person feels. That's what we make our decisions when it comes to clinical decisions and treatment decisions are about how you feel. And I think people get really in the weeds when they start to talk about, balancing your hormones. What does that even mean? I don't really understand what that means, because if you think about a menstrual cycle, you're, in your premenopausal time period, you've got hormones also changing all the time. So what do you mean balancing? Are we doing it like on day 2 of a menstrual cycle, or is it like day 17 of a menstrual cycle, or what are we trying to mimic here? I think it's really misleading and makes it so complicated. This is what I see, on my Instagram. It's like, it does not have to be this complicated. It needs to be as simple as possible, because it needs to fit into your lifestyle and you need to feel better. Anybody that's making this complicated, in my opinion, is trying to sell you something.
Yep. And I love that. And that leads me to asking, how do you use, knowing an HRT really is just one piece of the management system, right? When we're perimenopausal and postmenopausal and our symptoms, how do you use things like nervous system regulation and sleep and food? And I'm sure that comes into play every day talking to your patients.
Yeah. I mean, we talk about, our the spokes of the wheel of your life. And I always say that HRT is only one spoke. We have to address all these other spokes. And I have a dietitian on staff, and she's my patients, and she, meets with everybody. Talks about fiber and protein and, what people need to be doing, and making sure that they're fueling themselves. That's a huge other, topic that I talk about a lot, is that women are just under fueling themselves and starving themselves. And it's just awful. I also have a mind body therapist here that does meditation, mindfulness, and works with my patients on, meditation, whether it's around sleep, whether it's around food noise, whether it's around intimacy. There's always an issue that needs to be addressed. And I do, sleep is a huge issue for most perimenopausal women. Occasionally I will have a unicorn come here and be like, no, I sleep great. It's very rare. Most women aren't sleeping. And if you don't sleep, you're grouchy, you're tired, you're going to make bad decisions, you feel fatigued all the time. Often just fixing sleep can be the biggest, overcoming the biggest barrier to your health.
Yeah. How do you feel about things such as melatonin? Are there any sleep aids out there you really do like or really don't like?
I like melatonin. I have patients that take melatonin. I have patients that use CBD. I'm not really against any of that. I think, a lot of times it's a progesterone estrogen issue. What I don't like is when I get patients in here and they've been started on trazodone and, lorazepam and I don't know what to help them sleep, and nobody's done anything about their hormones. My approach is, let's see what we can do about your hormones and see if that can help you sleep. Because a lot of times, I would say 9 times out of 10, that resolves the problem of sleep. And then if we're not getting enough of a response, we start to kind of pick away at other things and see what else we can add to kind of the cocktail to help you sleep. Yes. But I can't stand when patients are given this polypharmacy of, 6 mostly addictive medications to try to help them sleep. And then they're falling down the stairs and because they're sedated essentially. And then when actually, if you just, thought about it for a minute and talked about their hormones, you could resolve the problem entirely for a lot of them.
Yep. And do you find the same for anxiety and depression in this age
Totally.
group?
I
Yeah.
mean, and they all end up here on SSRIs. Not that I'm against SSRIs, not that I'm against any medication. All medications have their time and place, and they're so useful. And SSRIs and SNRIs, they change the treatment, of people with mental health problems.
Yeah.
And I'm not knocking that at all. But what I'm knocking is the 38, 39, 40-year-old, 42-year-old woman that goes to her PCP and she's having trouble sleeping and she's not coping with her stress and she's crying and she's anxious. And the first thing that comes out of their mouth is an SSRI.
Yep.
The problem with an SSRI, again, great drugs, but they cause low libido. They can't orgasm. They feel flat. And then you've just compounded a whole bunch of the other perimenopausal symptoms they already had and made them worse.
Yep. Yes. And that, again, all of you listening, like take that, just look at it as your symptoms as a whole. And I love this idea of, yes, a GP or family physician who can look at each part of it, because it really can all work together. I mean, it just feels like, oh my gosh, if I can solve one thing, I feel like it's dominoes that they would fall. And that's what happens when we're in this time and our hormones are going crazy and we're losing estrogen and we are anxious and we're taking care of our parents because we're the sandwich generation and we have young kids. And I mean, it all comes together. So just finding someone to listen to you and who has that full body approach, I think is just so valuable.
And it's just so overlooked, again, because our healthcare is built on, everybody's in their lane, nobody's prepared to kind of take a kind of, 30,000 foot view of where we are and what we're doing and who's doing what and what can we kind of centralize again.
Yep. And just out of my curiosity, does insurance cover, I mean, it sounds like what you offer is so amazing and kind of, like I said, kind of whole body. Is insurance covering that, or are they paying out of pocket, or is it kind of both?
So I don't take insurance.
Okay.
I did try at the beginning. It was didn't really work. I spent a lot of time with my patients. We have a very, a specific approach that we're just not going to get covered by insurance. So, but we do offer super bills, and I have some patients that do get them reimbursed. So it is very variable though.
Yep. And that too, if you're listening at home, there are options. Like there are so many people now, because our healthcare system doesn't cover what you need half the time. It just doesn't.
Yeah.
That doesn't mean there isn't someone out there to listen to you. Again, is it your oncologist? Is your family physician, your OB, whoever you need to start with, start there. If you need insurance to cover it, again, just find someone who will listen. But then also, look at other options. Can you possibly get it covered yourself? Could you see your family physician and then have this one adjunct therapy? There can be options.
And I think, we have a tendency to not prioritize our health financially.
Yeah.
I hate to be the bearer of bad news, but like your insurance is not going to save you. Yeah. Your health insurance is not going to save you. It's not going to make your life longer. It's not going to make your life better. And if you are committed to those things, then you need to find a way to pay for them. Hopefully, healthcare will come around and it'll be better, but right now it's not. So if you want to prioritize your health long-term, your longevity, your bone density, you're going to have to look other places. And if you think about it, like our basic membership is $250 a month. That's a lot less than people spend going out to eat or at the liquor store, or, you know what I mean? And so it's not so much about affording it for a lot of people. It's about choice, about where am I choosing to spend my money? And that's a conversation that you need to have, and maybe like a little bit of a rethink about re-strategizing how you approach that. What is, does going out to eat take priority over my health? And that's a choice, and everybody has a choice in the matter.
Yep. Do you find, does insurance end up covering the HRT most of the time, or are they
so we do work
that?
on getting medications covered. We work hard on that. So we do a lot of prior authorizations. We scavenge for coupons. We scavenge for, pharmacies that are doing things differently. So we do work really hard to try to get their, medications covered, whether they're hormones, whether they're their, vaginal treatments, whether they're GLP-1s or some of the other weight loss treatments or whatever we're trying to do. We do work hard to try to get those covered.
No, that's great. And leading into something else I've heard you talk about, and I love the subject. I think it's so important and it isn't talked about as much. Again, I think just HRT is having a big moment right now, which is important. But like you said, there's so many spokes on the wheel. Talk to us about metabolic syndrome a little bit, about what that is, because I have a feeling almost all of us in this age group are dealing with it, and a lot of our complaints come back to that.
Mm-hmm. So if you think about one of the big effects of our hormones on our body, so I like to talk about estrogen, testosterone in particular, because this also happens in men when they lose testosterone. That one of the big things we have to understand is as we lose estrogen and testosterone, we develop some insulin resistance. So, what is insulin resistance? So if we think about what is insulin, insulin is a hormone released by our pancreas in response to a rising glucose. So you eat an apple, your blood glucose rises, your pancreas detects that, releases insulin to the bloodstream. That binds all the insulin receptors, opens a channel, allowing that glucose to flow from the bloodstream into the cell to make energy. Me and you are making energy from glucose right now. It's a fundamental function of our existence. As a result, your blood glucose falls and order is restored. And that's how things have been going for, 30, 40 years. As we lose estrogen, we start to become insulin resistant. So what does that mean? You eat an apple, your blood glucose rises, your pancreas detects that, releases insulin, and nothing changes. So it's like, I got to release more. So release more insulin. Now we're in a situation where we need much more insulin for that dose of apple than we did before. And that's a problem because the higher your circulating insulin level, the more fat you will deposit, particularly metabolically active fat in your middle. The problem with that is I call it kind of drama fat. It's dramatic. It's busy kind of doing bad things and laying itself down in your arteries. So often we see concurrently that your cholesterol will rise, your weight will rise. For a lot of people, their blood pressure will rise. And that's kind of the nub of what metabolic syndrome is, right? It's insulin resistance associated with a cholesterol that's abnormal, associated with a rising visceral fat. And it is a disaster for your cardiovascular system. Puts you at significantly increased risk of cardiovascular disease, of type 2 diabetes. And that is the number one killer of women in this country is cardiovascular disease. It's a perfect storm of metabolic syndrome and then the inflammatory response of losing estrogen. And you put those together and it creates a nor'easter, as they would say here, of a mess. And that is what leads to cardiovascular changes.
Yep. And what I would say, I love what you called it, the drama, because that is true. Because what we all hear and the big message on social media is, oh, get rid of your belly, get rid of that midlife belly. I mean, that is my pet peeve from messaging standpoint.
Mm-hmm.
Like, okay, you can't just work your way out of by more workouts. It is such a deeper issue. It doesn't mean we can't do anything about it.
Mm-hmm.
But yes, I mean, and that is what people see, I think, for a lot of us and what I hear in the fitness space, a lot of women, that is the number one thing is, oh my gosh, I suddenly have this fat around my middle. I never had it before.
Mm-hmm.
I don't know what to do about it. And I feel like that is just an entry into a hole for us sometimes, this spiraling of it's not my body anymore. It's not me. Everything's changing. What is one or two strategies women can use when they start to feel some of these symptoms? Or like you said, they're just eating the same, but it isn't kind of feeling the same in their body as it used to.
Yeah. So it would come down to what can we do to improve our insulin resistance? That's going to help us to improve our body composition. And that's going to be fueling adequately, right? So eating the better foods, right? So staying away, making sure we're adequately fueling with fiber, we're adequately fueling with protein, staying away from the kind of processed foods, the high sugars that are not doing us any good, and then weightlifting. The conversation around how to lose menobelly and how to lose your midlife belly, and it's always kind of on Instagram, it's like the running on the treadmill and doing the whatever, and it's just so unfortunately we've been conditioned as women the way that we were, the kind of the noise that was there when we were raised, that we have to do all this cardio and we got to run on the treadmill and we got to go up and down on the Stairmaster and just, I did step aerobics for years, and I was jumping around like a crazy person for years and years and years. And actually that's really not going to get you very far in terms of improving your long-term health and improving your insulin sensitivity. What's going to get you far is building your muscle and increasing your muscle mass, because muscle loves glucose. And if muscle loves glucose, then it's going to improve that insulin sensitivity and your blood sugars will therefore improve. And it's sort of, a domino effect after that. I always tell people HRT is not a weight loss drug. HRT is just trying to kind of turn off, you've like your check engine lights on and the HRT is trying to turn that off so that things maybe work a little bit better. but it also takes work from ourselves. We have to eat well. We have to, fuel our bodies. We have to weight lift. We have to sleep well. We have to manage our stress. There's all these other aspects of this that we need to also address.
Yes. And I think when I started to just accept that, oh, this is a job right now, right? Like this is going to take more time out of my day every day to actually support and nourish myself during this time of life. And it's so vital. I mean, I took care of my mother-in-law with Alzheimer's for years, and I saw exactly what you talked about. I mean, she wasn't served. She had suffered so much. I'm like, I will do whatever it takes to take care of my body now to help myself later on. But it does take work. I mean, anyone who says it doesn't is just wrong, or they're not doing it. Because you have to commit. I mean, committing to sleep takes work. It means I say no to other things.
Yes.
Committing to my workouts takes work. I say no to other things, or I bring my kids in with me and say, we're going to lift for 20 minutes, guys. And it just does. Even with HRT, if you add that to it, you still have to do the work.
100%. It's work. You have to, it takes commitment, and that's why I tell people this is not a one and done. You're not going to come here, have an appointment and get your patch and be like, this is good. There's all these other things we have to do to make sure that you're the best person that you can be in 20, 30, 40 years.
Yep. And mindset is a part of that too. Like you have to realize you're worth it and you're worth the time. And talking about our age group, that can be a hard thing sometimes. We don't.
And that comes down to, again, women, and that comes down to spending the money. Let me tell you, the men, they're out there getting their, penile injections and they're doing their thing. They don't have any problem spending money on themselves, and you shouldn't either. You need to prioritize yourself so that you can get the best care that you need.
Yeah, absolutely. And then you can take care of those people around you better also if you're serving yourself. And if you have daughters in your life, you are teaching them that they can take care of themselves. Because I will say that's what we didn't see, right? We did not have women role models taking care of themselves in that way.
No, we had women role models that didn't eat anything. That was, moment on the lips, a lifetime on the hips. That was the mantra. That was, nothing will feel as good as skinny feels, or taste as good as skinny feels. Like that was the mantra. That's what we lived by. We were like, you got to eat as little as possible and, be quiet.
Yeah. Yep. Which luckily we're not quiet. That's why we're here, because we're not the quiet ones. That's the point. And we don't want you to be quiet listening either.
No.
So teaching people to use their voice, what are, like, if you could give people, I don't know, 3 different things to go research after this, or 3 different things to ask their doctors, what would be like an easy, hey, here's your to-do list to start?
I would get a DEXA scan.
Okay.
Get a body composition and a bone density. I would say that is huge, because I can't tell you the number of women that come in here and they're like, oh yeah, no, I'm strong. I do all this and that. And they go in the scanner and they've got very little muscle mass and osteopenia or osteoporosis. And then they're shocked and they're leaving here in tears. So you need to know your numbers are. We need to know where my muscle mass is, what my bone density is, because then you can really prioritize what comes next, right? So if you think about HRT, for example, people are always asking me, when do I start HRT? But when? And I put HRT into 2 buckets. One is symptoms, but then the other is prevention. So for symptoms, I'm like, when you have symptoms, take HRT. But then prevention, if I have somebody go in the scanner and she's 35 and she's got osteopenia, and I'm going to be on her about when we start HRT, because I don't want her to develop any of the bone loss that we know we're going to see in those shoulder years, right, before her last period. So I might be a little bit more aggressive about my approach to hormone therapy for that person to manage her bone loss. But if we didn't know that, if we didn't put her in the scanner, how would we have ever known?
Yeah.
She probably, like most women, get their diagnosis of osteoporosis at their first fracture.
Too late.
Yeah.
Too late. Yep.
So get a bone density, get a body analysis. I would say those are 2 big things. Check your blood pressure. Simple. Let's think about what your cardiovascular risk is. Get your blood pressure checked regularly. Get some lab work, particularly cholesterol, fasting blood sugar, insulin. Get your insulin level checked. That's really useful. We see a hemoglobin A1C. Just because your blood sugar is normal does not mean you don't have insulin resistance. If you're going to think about, by the time your blood sugar is normal, this has been cooking for 15 years, right? By the time you start to have abnormal fasting blood sugar, you've missed years of potential prevention that you could have instituted. So what we're trying to do is detect that earlier. But to detect that, we're going to need to do a little bit more testing. So your fasting insulin, your hemoglobin A1C, so we can see if you're trending in that direction. And then again, we can intervene and prevent the progression of that disease instead of waiting for the disease to develop and then trying to backtrack from there. So get a bone density, get a body analysis, know your lipid parameters and all your blood sugar and insulin parameters. So those would be huge. And then, some doctors are like, well, it's not covered by insurance. I would say go to Quest, go to LabCorp. You can get a cash, you'll tell you how much it costs. You can pay for it right then and there. It's not expensive.
Yep. And then you can take that blood work with you for whoever you see. Exactly. And just for accessibility purposes, I know there are many, and you can tell us actually if you do, there are many practitioners who will see you through Zoom. Like if you can get that local blood work done or the local scans, you can see someone right here virtually who can talk through that with you and help you know what you need and where to get it. So don't let, I know many people out there do have accessibility issues and I wish I could fix it all. There are some options now that we didn't have 10 years ago.
Mm-hmm. Yes, I would agree. The more information you can have at the outset, the better. The way that we run it here as members, our members get everything included. They get their labs, they get their DEXA scans. And so it's different, but a lot of telehealth, some of the more information you bring to that practitioner, the more that they could, help guide you really. And, sometimes it's worth even just paying for one visit. And if you have labs and you have DEXA, you're going to, get the most possible out of that visit that you're paying for so that you can be at least signposted in the direction like this, you need to pay attention to this. If you were going to do HRT, I would suggest this. I would recommend that. And then you can bring that to a provider that's more willing to, maybe in your area, that is able to prescribe for you. But even having that information and having that discussion, the questions people ask me on social media, I wish I could answer them. They're so specific to them. And I wish I could answer, but first of all, I can't answer. Yeah. And also a lot of the questions are very, around the nuance of hormones. And, you need to have a one-on-one conversation with that person really to help them to understand and educate them about what actually is, what the approach is, what's correct, what we shouldn't do, what we should do, how we combine things, so that they have the basic of education instead of going into a primary care office knowing almost nothing and then being told things that are inaccurate and then coming away with nothing and inaccurate information.
Yep. And for those listening too, you might be saying, oh, I'll get a DEXA, insurance covers it, I think after 60 or 65, right? I don't remember that.
Medicare will cover it after 65. Some insurances will cover it after 60. Okay. There are some pre-qualifying conditions. So for example, if you have celiac disease, you can probably get it covered. There are sometimes family history, although I don't find that gets through past insurance very well. But I will tell you that I would ask. Yeah. So the DEXA scan that's covered by your insurance is a little bit limited in information. So they have the ability. So a DEXA scan that's covered by insurance looks at two parameters. It looks at your lumbar spine bone density and your left hip. Mm-hmm. So if you go somewhere else and pay for it, you can often get a lot more information. So we do 5 parameters. So we do your lumbar spine, both your hips and your non-dominant forearm, but we also do something called TBS, which is trabecular bone score. So TBS is a measure of the microarchitecture of the bone. So it can give you an idea about potential tensile strength of bone, which sometimes is not. So there's a criticism of bone density. Just because the bone is dense doesn't necessarily mean the bone is strong, right? And the only way to really test tensile strength is to try to break a bone, and we can't do that to people. So we need to find other ways that we can potentially measure that, and TBS is one of those. So taking those together, the information from the TBS and the information from the bone density, is a lot more valuable together than it is with the bone density alone. So I would say, even if you're considering, consider maybe paying out of pocket for one. And when you do, asking actually what they do on the DEXA scan and how much information that they're going to give you.
Yep. And I completely agree. And you are not the first one that I've heard have this conversation. I have been a part of so many conversations saying DEXA should be covered earlier. By the time we have that DEXA scan,
too late.
It's too late. Then you get on medication. There's not much you can do for prevention at that point. There are some things, okay? It's never too late. So don't hear me say that. It's never too late. There are always things you can do. And we don't want to cause fear whatsoever. But yes, this is great information to have earlier if you possibly can have it. So considering that, and like you said, then you have it and you can take it to whoever you're seeing who can
Correct.
really read it and understand how it fits into that bigger puzzle.
Yeah. Yeah. I've seen endocrinology reports, and they say things like in a 40-year-old with osteopenia and osteoporosis, they've been advised not to pick up heavy things. And I mean, it's just, you just want to just wish the ground would open up and swallow you whole.
Oh, absolutely.
So, there's just so much misconception around bone density.
Yes.
It's like frailty begets frailty. Mm-hmm. If you allow yourself to be frail, you will become more frail. You're in this like endless cycle of spiral downwards. And, intervening early and quickly and effectively is going to change the outcome of your life.
Yes. Yep. And putting in the work to lift weights, like you said, and doing it in a safe way, but don't let fear stop you from moving in any of these
100%.
ways. Don't let fear from breast cancer stop you from just asking the questions if you can feel better in your body. Don't let fear of osteoporosis stop you from lifting weights. You can follow the fear-based track, or you can just reframe it and say, I just need more information. Information will empower me. I'll know what questions to ask. I can be an advocate. And then you can have loud voices like we do.
And fear is how people are controlled, right? If you think about people that are abusive, it's everything, you're ruled by fear. And that's how people have power over you, is with fear. And so it's learning that there's nothing to be fearful about. You are the locus of control here, and it's up to you to decide what you want to do. One of the biggest injustices to women was that they made women, with the whole breast cancer conversation, afraid of a hormone that they make in their body. It's like they've convinced us that the call is coming from inside the house.
Yeah. Yes.
I mean, it's just, if you think about it, it's wild and that's going on for decades. Yes. It's totally unacceptable to let women think that the estrogen they produce in their body is their enemy.
Yes. Yep.
Shocking.
Yes. And if you all go to breastcancer.org right now, that breastcancer.org is having a discussion around how vaginal estradiol is safe and actually is increasing. It can increase the lifespan of breast cancer survivors, vaginal estradiol. So go read it, go look, do your research, take the information to whoever needs it, and then make the choice that's right for you. Maybe it's HRT, maybe it isn't, but knowing that.
And don't forget that HRT, even for a breast cancer survivor, let's say, I do have breast cancer survivors that I do treat with estrogen. I do. And, because what, she's a big girl and she can decide.
Yeah.
But also, maybe it's not estrogen. Maybe we do testosterone.
Yes.
Maybe we do progesterone alone. Maybe we do progesterone and testosterone. What are we trying to do? Just, this blatant statement, nothing upsets me more than blanket statements. That people make blanket statements like, people with ADD won't tolerate progesterone. Like, stop. Enough with the blanket statements. That's not helpful. And they make blanket statements like, oh, HRT, you can't take HRT because you've had breast cancer or because I have high risk of breast cancer. Again, blanket statements aren't helpful, but also you're basically saying HRT is only estrogen, and it's not. Yeah. Right? If your biggest issue is sleep, why can't we just do some progesterone? If your biggest issue is terrible fatigue, why can't we do some testosterone instead?
Yep. That's great. That's so perfect. Tell everyone how they can find you, where you are. If they want to see you in person, where are you online, all the things.
So I have an online presence. I'm on Instagram. I can't do the other ones. It's too much things. Yeah. So I'm asked Dr. Noor on Instagram. And I practice currently in Exeter and Bedford, New Hampshire. And my website is lifestylesbynoor.com. And you can book a appointment. I am currently licensed in New Hampshire and Maine. I'm working on Vermont. I can see people from outside if they want to do a one-off consultation. I can't prescribe or kind of care for you medically. But if you have lots of questions that you want answered, that's something that I can offer as a one-off appointment as well.
Oh, that's amazing. And I will have all those links below. So we'll have them down in the show notes. I just cannot thank you enough. I want to go back and re-listen actually to this right this moment. I know it was so powerful. Thank you for taking the time out and for everything you're doing for women's health.
Thank you.
Yep. Thanks. Bye. Thanks so much for listening today. I would love it if you could take a moment to subscribe, rate, and review this podcast. It means a lot to us and it helps our content get out to more women who need it. You can find more of my resources at my website, jessicavalant.com, or find me on YouTube at Jessica Valant and Instagram at Jessica S. Valant.